Hey, welcome everyone. Thanks so much for joining. I see a few people are still trickling in, but let's go ahead and get started. So just quickly to start us off with the agenda today, I'm going to do a speaker introduction, and then our speakers will go over the challenge, just giving a quick overview, the challenge timeline with some important dates, discuss a bit about the challenge data and the evaluation metrics, and then we'll open it up to the audience Q&A. Just thank you to everyone who has sent in your questions earlier. We'll definitely get to those. So just a note that this is being recorded, so we'll post it on the webpage after the event if you want to rewatch it. And we'll also answer all of the questions in a written format and post it on the website so you can refer back to it. Okay, so now I'm just going to hand it over to Mark Ansermino to introduce himself, and then we'll pass over to Rishi after.
Hi, hi everyone. My name is Mark Anselmino. Thank you very much for joining us today. I first of all want to thank Charlie Huxford, who's done most of the work for this project, and she didn't do a good job introducing herself. So Charlie is a research coordinator in my team at the University of British Columbia. And thanks to Charlie for all the work she's put in. And this has taken like nearly 2 years, probably, Rishi, for us to sort of get to the stage that we're ready to launch this, as it takes an enormous amount of work, but we're very excited to get this going. So I'm a pediatric anesthesiologist intensivist by training. I'm a professor at the University of British Columbia, and I'm the co-director of the Institute for Global Health at BC Children's and Women's Hospital. Over to you, Rishi.
Hi, everyone. My name is Rishi Kamaleshwaran. I'm an associate professor of surgery at Duke University in the School of Medicine here, and I'm a computer scientist by training. I've done a number of work. I've contributed a number of work in the pediatric sepsis area, which I'm really excited to partner with Mark to work towards disseminating this data set and encouraging more contribution in this space. So I'm excited to be part of this and looking forward to working with you, all of you.
Thank you very much, Rishi. Next slide, please. So first of all, maybe to tell you a bit of a background of this thing is that I am the clinician and Rishi is the engineer. So just so we're clear about the contributions to this particular challenge. Of course, for my whole career, I've had the privilege of working with a number of different engineering and computer science colleagues over the years. I did some training in health informatics in my youth, but at the end of the day, it's really understanding how important it is for clinicians, engineers, and computer scientists to come together to be able to solve these challenging problems that we have in the world today, and particularly in healthcare. So the idea of this challenge is really to bring everybody together, to introduce you to new people, to develop new teams, to develop new collaborations. So we would certainly welcome any feedback during the challenge. You'll appreciate we have given a period for us to sort of settle into the challenge, to completely define exactly what the metrics are going to be used. But just to say to everybody, this is really our first attempt to do this. And we hope to continue to do this in the future. But the most important thing is to really develop the skills of individuals. So those both clinicians and the technical engineering computer science experts, but really to catalyze those new collaborations, because to really do this effectively, we do need experts from both sides. So the ultimate goal of the challenge is to develop an open source algorithm. So we do insist that this algorithm will be made publicly available. And what we're trying to predict is in-hospital mortality in children. And the challenge has a number of components that we'll talk about. And maybe I should put some context around why we would want to predict in-hospital mortality. So traditionally, every child is presented to the clinician with the clinician really allowed to make clinical decisions based on their clinical knowledge, on collecting information from the patient. But more and more, as we move into this world of data-driven medicine and data-driven care, we get this concept of risk-differentiated care. And the idea really is that every patient is not necessarily treated the same, and that we do need to differentiate how we treat patients based on what their risk is of some outcome. And in this particular challenge, we're using hospital mortality as an outcome. And we use this as the outcome because obviously it's a very definitive outcome for us to measure. Nobody will have any question when we tell you that this is the outcome. It won't be left to me as for interpretation. This is a very definitive outcome. But of course, we've got to develop the algorithm in context of what the clinical scenario is. So when we look at outcome, one could argue, and this may be in certain situations, where if we could predict that a child was going to die, we would not waste our precious clinical resources on this patient. That is not what this challenge is all about. So that may be in some, massive pandemic situation or some other situation where one has to decide, like in some mass disaster or something, where you have to decide who do you spend your resources on and not treat some children. That is not the goal of this algorithm. This algorithm is really trying to predict which children are at higher risk so that we can take some action based on that risk. Now, we are not going to predetermine what that action is going to be, but to give you some idea of what those typical clinical actions that we would take, for example, would be if I saw a child was at high risk of in-hospital mortality, I might put that child in a location in my hospital that received a higher level of care. So that may be in a high dependency ward or an intensive care. And in many places in the world today where a lot of these algorithms are used, and certainly in the facility where this data was collected, there weren't such facilities, but this child could potentially be put at the front of the ward near the nursing station to make sure that that child got a bit more care. An alternative solution, and something we're certainly working on, is could we institute continuous monitoring on this child? So, in most high dependency areas, in high resource settings, we would continuously monitor the child. This is obviously not the standard of care in many of these locations, but we could institute a program of continuous monitoring of this child if they were determined to be of higher risk. So that's maybe giving you some idea of the context when you're developing these algorithms of why we want this risk differentiated care. And of course, that's going to depend on the context. It will depend on the context of, how many nurses they have, how big the ward is, how many children are around, how severe is the caseload that they have in that particular facility. So there may be many different things within that facility that will determine what those actions are going to be taken on the algorithm. But I think it's really important that we don't just develop an algorithm because we're good mathematicians and we can get a good score. We develop this because we really want to drive clinical change based on these algorithms. So that's just a little bit more of the overview of where we came with this challenge. And this data was collected around a research program that we had. So this was very intense, well-collected data that was done in a program where we were looking at children who died not in hospital, but died once they had left hospital. But of course, we collected all of the data at the time that they were admitted. So most of the data we had, 90% of this data happens from when the child was admitted at the time of admission. And in the previous research that we published, we looked at, what we could predict after they left the facility, because obviously, once again, we can take actions to prevent that those children that go home don't die. But we haven't previously published on this. So these will be the first attempt for us to try and model that. We did do on an older data set, we did publish a paper in the past that you may find looking at in-hospital mortality. We did produce a model which you can certainly use to inform your what you do going forward. So this is open to teams of 2 to 5 members, and we did want to make the teams fairly small, not to make them huge teams. And we're going to talk a little bit on how we're going to build the team. So we would really like you to work as a community. And there is a discussion group that Charlie is creating in Google, and hopefully all of you can participate in that. And I do notice that there's some people that have put their names there who are looking for joining a team. So I'd encourage you, if your team's not full and you're looking for somebody with specific skills, whether that's technical or clinical, to go to that discussion group and invite other people to join your team. And of course, what we're really trying to do is provide some resources, and I've tapped a few people that I know to try and support those people who don't really have access to the expertise that they need to be able to do this. And particularly in low resource settings, we really want to encourage people to come and join us from those settings, whether they clinical or technical, so that we can start these new collaborations. And of course, as we move forward, we hope to be able to catalyze that and catalyze these new collaborations. And we'll talk a little bit more of how we plan to do that. Next slide, please, Charlie. So this is the timeline. Charlie, I don't know if you want me to walk through this, but basically, in a few days' time, the challenge will officially launch. The registration deadline is on the 11th of December, and every team, but hopefully by then, we'll be able to pull the team together. So between now and the registration, we need to pull the teams together so that we can register the teams. And you can give your teams, nice names that describe your team that you can use on the leaderboard that we're going to have, so that each of your teams can be registered there, and everybody knows who's there. During this initial preliminary phase that ends on the 11th of January, Rishi and I and the rest of our team are going to work together to finalize some of the metrics that we're going to need to do the evaluation of what's happening within the program. And we appreciate that there has been, some confusion around this. This is obviously a difficult thing to do, but what we really want to do is we need to do some more work to make sure that this is going to be robust. And I think is what's reflected in a lot of the beautiful questions that you sent us, that we do need to weight this more than just pure performance of the algorithm. There then is going to be the active phase where you can start submitting your algorithms during that phase. And as we mentioned, this active phase, we will be able to take algorithms from you and run this on the real data, the original data that we use to create the synthetic data set. So just to clarify, you will be provided the synthetic data set, and the reason you've been given a synthetic data set is that we've done lots of work looking at the risk of re-identification. And unfortunately, we have, very clearly shown that if we gave you the real data set, there would be a risk of re-identifying patients that are in the data set. So your algorithms will still be run against the original data set, the real data, but that will be done by our team. And we are setting up an environment that we'll be able to run those algorithms, and we will be able to give you the results of those algorithms based on the metrics that we'll provide within the framework that we have developed. Of course, you will need to develop your algorithms so that we can actually do that. And then this will be announced on the 26th of May. Okay, so just a little bit about the data, and I seem to be doing all the talking, Rishi, but so this is a de-identified data set from a study that enrolled children under 5 years of age who were admitted with a proven or suspected infectious illness. The data set is limited to the in-hospital period and contains clinical, social, and demographic data captured at the point of hospital admission. There's also some additional information in there that we will flag in the data that is, for example, antibiotics administered, the length of stay. So there is some additional data, but of course, this data is not going to be very useful for predicting. What we want to do was predict mortality at the time of admission. Okay, so it really is this time point that's going to be important. And what we'll provide you is the synthetically generated training data set. And obviously this was generated to reduce the risk of a de-identification. And we've done quite a lot of work, which you'll see in the publication that accompanies this, in trying to make sure that this accurately reflects the original data set. But the solutions will be evaluated against the original data set. Rishi, your turn to talk.
Thanks. I'm just trying to find my unmute button. Yes, so we're considering a variety of evaluation metrics, but many, the crux of the primary metric will fall on model performance, and we are looking specifically at different aspects of sensitivity, specificity. We've predefined some of these criteria that you're seeing here. And so these are set based on what we had identified as potentially clinically relevant in this current scenario. We have fixed some of these metrics, but as we go through the initial preliminary phase, we will develop some of the further saliencies of the actual final metric, and we'll make sure to announce them to the group when we are at that point. But just to generally, describe, since this is a binary outcome, we're not specifically, looking at, and also this is a point estimate. We're not specifically looking at other permutations of the prediction, such as longitudinal or autoregressive or any of those metrics. So we think that this is from a benchmarking standpoint, this will be a fairly, I would say, not simple or easy, but fairly straightforward benchmarking from a clinical performance standpoint. We're also considering other metrics like computational complexity and time complexity. These are things that will be described as we go through the preliminary stage. While we're not prohibiting anyone from utilizing models that are overtly complex, we are emphasizing here that you have to keep in mind the practical utility and use case that this model may be applied to in the future. So we will have more to share over the next several weeks and months to come. But this is a generic overview of where we are at right now. Thank you.
Thanks, Rishi. Just a couple of other comments on that. Parsimony is the other really important issue that we will address with developing models. And that's really, obviously, from a practicality point of view, the fewer number of predictors that you would use in a model, the more practical it is for implementation. And we are busy really rating. And I think what's related to is that sometimes collecting a piece of information may be more difficult or requires some technology to be able to collect it. And of course, there must be some balance between, how difficult it is to collect that information against what the value of that information is in the prediction. So we are working to come up with some score that would reflect that. And I would really say at this stage, for all of this, we understand that all of these scores require some judgment. So we will need to make a judgment call on, what's an appropriate false positive rate, or what is appropriate computational time or complexity that's required for this, or, what's the balance between various predictors and the number of predictors. And you'll just need to bear with us that we'll try and do this in the most fair way possible. And we will certainly provide you the final score matrix that we will use for this, so that you will be able to do this yourselves and be able to train your models using the same criteria. But it is going to take us a little bit of time, and we need to look at the balance, as I say, between these various components to make sure that we get that right. And obviously would love feedback from you as we provide this. If you find that it's, too biased in one direction, we'd be very happy as we move forward before the final launch, before the final competition, to really get this right. Okay, next slide. So I know we've got some questions in the chat, and we will get to those, but I thought that we should first go ahead and take some of the questions that were provided in advance to us. And we really want to thank everyone. I mean, we've got some amazing questions. So Rishi, I've spoken the most. Why don't you start first with this, and let me know when your voice gets hoarse, and I'll jump in.
So the question around programming languages that are preferred, just due to the limitations we have in the environments where we're going to be executing the models, we are currently restricting those to Python and R, and packages that are readily available within those two environments. So that's the programming language of choice for us. Now, the other aspects of these, some individuals use proprietary tools like MATLAB and other components. So we're emphasizing again the open source elements of the competition. So we would like to maintain that throughout the entire life cycle of the challenge. So we are emphasizing the use of open source programming languages and libraries that them be used for these challenges. Question on whether there be anyone to take questions if they occur during the course of the competition. We have provided a link to the Google Groups channel that you can use to submit your questions, and our team will be there to provide answers. And we will be doing that throughout the duration of the entire competition. Would there be any post-challenge initiatives to further develop and deploy the winning models? I think this is an exciting area, and Mark will talk a little bit about this. I think there's a number of directions that we are thinking about, and certainly we will keep you tuned to the developments in the space. Questions on missing or handling of missing data as during the actual synthesis. So this has been published in some respect in the original paper. We're being a little bit careful about what we disclose because we don't want the challenge participants to replicate the nuances of the synthesis or the synthetic data generation itself, and focus on the task. We will, during the course of the competition, provide feedback on any potential drifts, data drift, or other types of inconsistencies that we are seeing when we do try to replicate this in the original data sets. And this will be identified. And this is the primary purpose of that preliminary phase, is to make sure that what is being submitted, that we minimize any of these potential challenges in replicating back to the original data. And we'll be informing the participants throughout that process to make sure that this is mitigated. What are the what specific challenges might arise when building algorithms using synthetic data compared to real world data? I think there are some legitimate concerns on processing using synthetic data, but keeping in mind the sensitivity of the data set, including the families and the children that are involved in providing this data, this is a risk that we are looking at very carefully, and in the course of the competition, as we implement these synthetic data derived models on the original data sets, we will certainly have an eye on potential errors that occur during that course, and we'll try to correct them as best as we can. Are there any restrictions on the type of machine learning models or techniques that can be used? We are not putting any restrictions on the types of models that can be used. We invite our participants to explore the full depth of opportune models that exist, including large language models and different types of current approaches. That being said, we are interested in teams that not only deploy these advanced tools, but optimize them for the use case, which means that they must be something that may be potentially deployed in a rural or frugal environment. So in addition to balancing the performance on the actual algorithm, you should also try to balance the resource constraints that exist in these environments. So those things will be clarified later. Any guidance on handling the imbalance in data set? We are not putting any requirements on how data imbalances are managed. I think there is a variety of ways to mitigate class imbalances, and there are advantages and disadvantages to all of those. So we are asking that the teams themselves, explore those choices and present their best approach for the final task. Thank you. And what are the expectations for deploying the algorithm on mobile devices, and how do we ensure model efficiency? Yes, so this again goes back to the previous questions around developing algorithms that are both accurate but also efficient. And there may be a slight trade-off in there, but we are that's a task that the challenge participants will have to optimize on their end. Are there any considerations for runtime memory usage? Again, goes back to the same point. We are not putting any requirements, but if your fellow competitors are able to achieve a certain accuracy that is higher, given a shorter runtime and a smaller memory usage, then those are more attractive. So we are putting this in the field so that can be actively considered. Can we adjust our models between the two phases, or is the official submission? So once the preliminary phase is complete and the official phase begins, there will be opportunities to update submissions. There's a certain number of submissions that can be exhausted, but we will then ask the final challenge participants to select a submission that will be run on the final holdout data set. And once they select that model, that will be the model that will be used for generating the official leaderboard. Can you provide more details about the baseline random forest classifiers that we provided? So this we will provide more information during that preliminary phase. What improvements or customizations are encouraged and above beyond the baseline model? This is the point of the challenge is to exceed the performance of what is provided in that baseline model while achieving a balance across efficiency and computational performance. How will the top performing model be validated externally before their application? This is something that we have not fully determined yet, but we will have updates throughout as we approach that final phase of the challenge.
Yeah, and maybe just to comment on that, Rishi, we do have additional data in a similar study that's just recently completed, that we would be able to do further external validation, but that's obviously not a component of the challenge at this stage.
Perfect. So how are the entries marked? What exactly are you looking for in the code? This is again described earlier where we are looking at entries or models that are able to achieve performance that is superior than their competitors, but also manages the other criteria to a lesser degree. But the primary emphasis is on making sure that the model can complete the primary task at hand. How will the true positive and false positive rates be weighted in determining final challenge scores? This again there'll be more details to come in this. We are looking at some of these metrics and the weighting that they're applied in a broadened utility function that will be shared in the next several weeks. Can you explain in more detail how the scoring metrics impact model evaluation? This again goes back to that question around the multifaceted approach that we're taking for model evaluation. This will play a part, but it'll be weighted with two other criteria. How will feedback be provided during the unofficial phase to refine the algorithm before moving into so the unofficial phase is an opportunity to make sure that the environment is working in terms of algorithms and models that are being submitted are executable, and we are not going to be providing feedback on performances or metrics in regards to the task of the primary tasks of the challenge. The unofficial phase will be primarily used to identify any technical issues with the implementation of these models. Next slide, please.
That's the end of our pre-sent questions. So I can maybe stop sharing my screen if you want to go into the chat. There's quite a few questions in there. Okay, sounds good.
Sorry, can I just start with some of the thing that was raised there and just maybe go into a bit more detail about what we intend to do around promotion of the challenge. So we appreciate that the primary sponsor of the Sepsis Collab, which is where this challenge came out of and where the data is currently provided open source, is really our main sponsor is WIFPIC, the World Federation of Pediatric Intensive Care and Critical Intensive Care Societies. And so that was the reason why this was published. The original paper to launch this was published in Pediatric Critical Care Medicine, as that is the journal that is linked to WIFPICS. We have also got, the confirmation that they will continue to promote this. WIFPIX will continue to promote the competition, and they have already done that. That's probably how you know about it. But also there is a meeting planned in the next WIFPIX meeting is in Melbourne in 2026. So there's a pitch for WIFPIX. And certainly we will have a special session at that meeting. But we would certainly look at having abstracts at other meetings as well. So we would certainly want the top abstract, as Matthias has mentioned, published in some proceeding that would come from a conference or a meeting of some sort. But we would also really be championing, and we've had some discussions with this around, pediatric critical care medicine, but I think there are also other potential targets that we could use that would be very willing to publish a series of solutions to this challenge. So I think that really is important, but these are still at early stages, so we can't promise anything. But certainly at this stage, we can promise that this would be announced at the WIFPIX meeting. That would be the idea, that it would certainly be a major session there. And we would very warmly, we would certainly have a separate session where we could present these solutions at the WIFPIX meeting.
And also, Mark, I'd just add that we are, the data is highly curated data from a prospective trial. It's not an observational study. The impact of models, or at least the impact of contributions in the space, given the data set that is available, I think is very unique, and the approaches that can be contributed can be both novel and impactful in many areas. So while we are pursuing some challenge-specific opportunities, I think the benefits to the community can be enhanced by pursuing multiple directions, which many participants will be able to avail from technical conferences and IEEE conferences and other things that may take the results of this challenge with great interest.
Yeah, and obviously this is really our goal, having got families' permission to use this data for these types of open science purposes. We really want to make sure that the world benefits most from this. So this is really the goal of what this challenge is all about. And obviously, success of this challenge will only help to improve the chances that these types of contributions to open science can continue. And that is certainly the goal. So Rishi, I'm going to start going through the chat. Please pick up some things. So Matthias, I know you gave lots of questions. I think most of them we've addressed. I think this question around the cost function, I think is what we said. We are going to come up with that cost function. I mean, just to give you my thoughts on how we sort of work through this, if you want to start some preliminary work to go on this, I think that any algorithm that has a higher false positive rate than 20% is probably not going to be clinically useful. And I think that that's what we have used a lot in the models that we've built for various settings before, and trying to decide, what is a reasonable cost function to use this, and then to maximize the true positive rate based on that sort of performance, which is really the base that we've used for this. And I think there is some logical sense around that we would actually use. But obviously now we've got to try and build in all these other parameters and look at the balance that we had, as we said before. So we would welcome any feedback as we move forward with this. Hopefully within the group chat, we can certainly discuss this at length and try to come up with some final algorithm that we will obviously make a decision at some stage towards the end of exactly what that metric is going to look like. As far as team members are concerned, the main reason for us doing this registration is that we do need to develop the platform so that we can look at how many opportunities can we give to each team. we don't have funding that's specifically funding this project. So this is all done in volunteer time. So just like all of you volunteering, all of us are volunteering to actually run this. So we've got to have some constraints on this. So we would really strongly encourage the teams to register so that we can get some idea of how many teams there's going to be. I'm not going to say that we won't allow late registrations, but we would strongly encourage you to register by the deadline so that we can make sure. And we may well decide to penalize late registration teams by maybe giving them less opportunities to evaluate, just so that we can be fair and so that we're not overburdening the people who actually need to go and run each of these solutions. And, just to highly stress that the emphasis, and you'll see in the instructions coming out, or to make sure that your solution will actually run within our environment. So, we cannot spend, millions of hours trying to customize the environment that we're going to run these to make sure that your algorithm will be run. And we will be providing careful details on how that will be done. So the synthetic data will be the same as it's generated from the real data. So we hopefully the structure will be the same. Obviously, the distributions will be a little bit different, but the actual structure will be the same. And we will provide a data dictionary that's got lots of information in about the data, what the data elements were. And also the data dictionary will include some of this ranking in what we believe would be the weighting that we would use around the difficulty of collecting each data element. Yeah, so Matthias, we're not using a third site. So at this stage, we hadn't planned to do an additional external validation, but we feel at this stage, because the training set, the synthetic data is different to the validation set, to add that extra complexity. But, we could certainly do that in the future.
Yeah, and please do register on the Google Groups. There's been a link posted in the chat, and also will be posted in the main website. This is going to be the main area that we are hoping to consolidate question and answers and have direct engagement. So if you register on the Google Groups and then post your questions there, it'll send out an email to all of us and we will respond, and others will be able to see those responses and benefit from those as well.
So this question about the data and the distribution of synthetic data, which is a real question. So this is real world data that the synthetic data was created from. It was collected within a randomized, well, not a randomized trial, but a clinical trial. So it's higher quality data than you would expect. We did stress that 30% of the data is missing, and this is not because it was badly collected data. A lot of this missing data is because there was some questions that were not asked of all patients. So there was sort of a series of questions that didn't require responses if a previous response had been negative. And that really accounts for a lot of the missing data. But this is the reality about of how we actually collect data. But we have tried to replicate that as closely as possible in the synthetic data set. But remember, all of you will have a number of opportunities to run your algorithms against the real data set. Yeah, so hopefully there will not be any difference, Matthias. I think that's what we'll respond to. So the question of mortality, maybe I'll take that one. So for this challenge, we are only looking at in-hospital mortality. Okay, so as I said, the original goal of this project was in actual fact to collect post-hospital mortality, but this data set will only look at within hospital mortality. There was lots of discussions. We do have, some mortality that happens for patients who self-discharged and died at home a few days later and everything like that. But I think for the sake of the, those were relatively few. So we felt that it was reasonable just to limit it to in-hospital mortality. So that's not 30-day death or anything. This is, all children, and these children would rarely be in hospital for more than 7 or 10 days. So we're not going to get to 30-day mortality rates or anything like that. This would just really be in hospital mortality. So we've got the links there. So this whole thing about resources, you will get more information around that. Maybe, Rishi, you want to comment on some thoughts that you've had on how you're going to do this computational time-based metrics.
Yeah.
It hasn't been finalized yet.
Yeah, and we'll share some more questions, but I think the fundamental crux of this is that we're looking for the best performing model in terms of those who can achieve the benchmarks described in terms of predicting the in hospital mortality. But we also, if we get multiple models that achieve a certain similar performance measure in terms of predicting the outcome, we are going to have second and third tier considerations, which also look at computational complexity in terms of how much resources are being utilized in order to arrive at this outcome. And then the other is time complexity, which is how long does a model have to run to generate the same prediction? And we're prioritizing based on the value that the model may have in terms of rural domains. We're prioritizing models that have the same performance as another model, but has maybe half the computational cost and half the time cost. So this would mean that we would, for every model that's submitted, we would capture the total resources that are being requested by that model. We would also capture the time that it takes to execute that model to generate a certain prediction. And we would then weigh them in a way that's not fully disclosed yet, in order to identify the total score that'll go into populating that leaderboard. So these are the three primary criteria that we're looking at. Model performance in terms of how good is the model in predicting in hospital mortality, and then weighing in concert computational complexity in terms of the amount of resources that are needed to do that, and then the time that it takes. That being said, if a model does take slightly longer time, but achieves superior performance, that longer time is not penalized in comparison to the overall task performance in terms of the overall utility weightage that's done. So it's going to be a multifactorial consideration. And when we do release the utility function, you'll be able to see what weights we're applying to each of these three criteria in order to generate that score that populates the leaderboard. And keep in mind that these are all benchmarks that are going to be applied to the holdout data set. And so not the data that's provided. So even if you're doing really well in the synthetic data in terms of getting really high performances, if you have overfit to that data set, you will know based on where your rank is on the leaderboard if you're getting very low scores. And you'll also know the scores for each of the three criteria. You'll know the score you're getting for performance, you'll know the score you're getting for computational complexity, and the score you're getting for time complexity. And the sum weightage of the three will go into populating your position on the leaderboard. So I see question, if the outcome is mortality, in what way is prediction task specific to sepsis? So maybe,
Okay. Yeah, I will do it. Can I also just deal with the one about the evaluation criteria of interpretability? Like, this is a great question, actually, Gus. So thank you very much for that. That's so important when one looks at clinical models and things that we're going to implement is really the interpretability. And we really worry about that at the time of, how do we actually action these in clinical practice? But I don't really have any good way that I think that we could measure interpretability in a scientific way. But if you have any ideas, please send myself or Rishi an email. We can certainly think about how we could add that to it. But I think it's a great question. So this question of relation to sepsis. So all of these children, so this data was collected in Uganda in a fairly busy facility, and it's these children were only included in this data collection if they were suspected of having an infection. So in that setting, this rather loose definition of sepsis is really used to include all of those children admitted with the clinical signs and symptoms of an infection. And that's the reason why we are specifically using the term sepsis in what we're trying to predict. And we would clinically classify all these children as having sepsis. And certainly, remember, all of these children are admitted to a facility. So whatever criteria we're using, unfortunately, we don't have better tools today for actually be doing this, but certainly for these children with suspected infection who would be admitted to a facility, we would certainly think that that's a reasonable classification of children with sepsis. Alex, I hope that answers your question. So children with trauma or burns or follow-up visits, etc., who present at the facility were not considered in this cohort. Yeah, so Matthias, this is a technical question. Rishi, maybe you can try and answer of this balance between using Python or R, and maybe this is something that needs to go offline a little bit about how you would actually weigh that.
I'm following that, Matthias. Excellent comments, and I think you're right in that for efficiency, it makes sense to try to use a lower level language like C or others. But I think given that almost most of those who are working on this may not be proficient in those languages, I think initially Python or R is being recommended, and then potentially we will work with those teams to convert those models to more efficient languages if those if we decide to pursue further opportunities there. Thank you.
Yeah, so Alex, I know this is getting very semantic in definitions of the difference between infection and sepsis, but in actual fact, it depends on what your interpretation of that is. And remember that many children can have infections that show no clinical signs of that infection, and that's very common, we think. But sepsis is really the host immune response to an infection, and most of the things that we see clinically are not are really a result of the host response to that infection. Esoteric things, I appreciate, but any other questions? I think we've addressed anything. If we've missed a question, please feel free to email Charlie or Rish or myself. Charlie's probably the best contact person. If you're not in a team yet and you want to get in a team and you haven't found team members and you're desperate, please contact Charlie. We are trying to do some matchmaking. And if you have space in your team, please just send a message into the group, and letting people know that if you still can take somebody else. And we look forward to moving with this competition. And please let other people know. We think this is a great opportunity for people to get their hand at, sort of running Python, getting a handle of what it's all about. And I hope every member of the team will actually be able to, by the end of the competition, at least run the model within their own environment to see what happens. And that's really the purpose of trying to do that.
I just want to also emphasize that please, if you can send any questions on the Google groups, that way, we don't replicate and overwhelm Charlie and others. If there's, many people sending the same question, those are usually better addressed in the Google group. So we're prioritizing messages on the Google groups. So if you have any messages, please send it over there. It'll automatically go to all of us, and we will respond, and others will know that we've responded. So it can be a central place for managing all this. Thank you.
Okay, and thank you very much once again, Charlie, for organizing. We're really looking forward to moving this ahead, and obviously looking for suggestions on how to improve this as we move forward. And please invite your friends and colleagues who are also interested in the space. Let them know what we're doing. And we would love to have more people from around the world who are involved in this. So thank you very much, everybody, for attending today while the time has flown by. And enjoy the rest of your day wherever you are. And thank you for joining us.
Thank you. Bye-bye.